Physiology and mechanical obstructions.
Okay, so remember, the clinical diagnosis of constipation isn't just arbitrary. It relies strictly on the Rome criteria. You actually have to meet at least 2 of these specific points, and they have to happen during at least 25% of all defecations. Whether that's straining, using manual maneuvers, or having fewer than 3 bowel movements a week. These objective measures are exactly what separate true clinical constipation from just subjective complaints.
Now, an absolute must-know for exams is Ogilvie syndrome. It's a profound colonic pseudo-obstruction, but there's no actual mechanical blockage there. When conservative measures, bowel rest, nasogastric decompression, when those fail, we turn to neostigmine. But listen closely to this part. Administering neostigmine absolutely requires a strictly monitored setting. Why? Because there's a huge risk of symptomatic bradyarrhythmia. You literally cannot give this drug on a standard medical floor unmonitored. Don't fall for that trick.
Check out this direct juxtaposition between sigmoid and cecal volvulus. Sigmoid volvulus typically shows up in elderly or institutionalized patients with that classic bent inner tube sign on X-ray, and you manage it initially with decompressive sigmoidoscopy. You decompress it first. On the flip side, cecal volvulus, that happens in younger patients due to congenital untethering. It gives you the coffee bean sign, and it demands urgent surgical resection. Do not try to decompress a cecal volvulus endoscopically. It requires a laparotomy, for sure.
Moving on to Section 2, diverticular disease and lower GI bleeding.
You absolutely must memorize the Hinchey classification. It is the universal dictator for your management strategy in complicated diverticulitis. Grades I and II, those represent localized or pelvic abscesses, where we can often just manage patients conservatively with IV antibiotics or percutaneous image-guided drainage. But the moment you hit grade 3 with purulent peritonitis or grade 4 with fecal peritonitis, yeah, you're heading straight to the operating room. That's typically going to mean an emergent Hartmann's procedure. Now follow this algorithmic logic for massive lower GI bleeding. Never, ever rush straight to the scanner. Always stabilize hemodynamics first. Focus on your ABCs. Then you place a nasogastric tube. Why? To rule out a brisk upper GI bleed that's just masquerading as a lower one. Only after you do that should you proceed down the diagnostic cascade. You go from endoscopy or colonoscopy to a tagged RBC nuclear scan for those slower bleeds, and finally to mesenteric angiography for precise localization and embolization.
Let's pause for a second and test our understanding here. Based on the Hinchey scale we literally just reviewed, what dictates the hard line for surgical intervention? It's diffuse peritonitis. Once a patient spills purulent or fecal matter into the abdomen, meaning Hinchey 3 or 4, that represents the critical threshold where surgery simply cannot be avoided.
All right, Section 3, the colitis, specifically IBD and infections.
So the absolutely crucial point here is knowing how to clinically and pathologically distinguish these two. Ulcerative colitis is a purely mucosal disease. It starts right at the rectum and moves continuously upward. And because it only affects the colon, a total proctocolectomy is actually definitive and curative. Now, Crohn's disease, on the other hand, is transmural. It features skip lesions, meaning they can happen anywhere from the mouth down to the anus, and it often presents with perianal disease. Crucially, surgery for Crohn's is not curative. You have to use highly tailored tissue-sparing interventions.
Switching gears to infectious colitis, specifically C. diff, do not forget that treating pseudomembranous colitis relies on oral, not intravenous vancomycin if metronidazole fails. IV vancomycin just doesn't penetrate the bowel lumen effectively. Furthermore, if your patient progresses to severe sepsis and toxic megacolon, well, that mandates an emergency laparotomy with a total colectomy and an end ileostomy. No way around it.
Section 4. Colorectal polyps and screening. Exams frequently test the genetics and the specific screening ages of these hereditary syndromes. You've really got to know that familial adenomatous polyposis, or FAP, involves an APC gene mutation that pretty much guarantees a 100% risk of colorectal cancer, and that's usually by age 40. Because of this absolute certainty, screening sigmoidoscopies have to start incredibly early, like at ages 10 to 12. Compare that to HNPCC, or Lynch syndrome, where the screening starts a bit later, at 20 to 25 years of age.
Okay, the Haggett and Kudo classifications are absolutely vital. They stratify the risk of lymph node metastasis from malignant polyps, which dictates exactly when a simple endoscopic removal just isn't going to cut it anymore. Notice that a Haggett level 4, which includes all sessile polyps by definition, or a Kudo SM3, meaning deep submucosal invasion, those absolutely require a formal segmental colectomy. You have to ensure adequate lymph node clearance.
150,000. That is the approximate number of new colorectal cancer diagnoses every single year. It's a staggering statistic, really, and it underscores the absolute necessity of initiating screening colonoscopies at age 50 for all average-risk individuals. It's literally a lifesaver.
Moving right along to Section 5, colon and rectal cancers. So, oncologic resections are highly standardized. A successful surgery requires a high ligation of the arterial pedicle to harvest a minimum of 12 lymph nodes. That number is key. Without at least 12 nodes, your TNM staging is considered inadequate. And once accurate staging is established, remember that stage 3, which means it's node positive, and stage 4, meaning distant metastasis, both of those mandate adjuvant chemotherapy, typically regimens like FOLFOX or FOLFIRI.
If you trace this algorithm with me, you'll see that rectal cancer treatment diverges sharply based on the tumor's physical distance from the anal verge. It's like a geographical map. A tumor in the upper third might just need a low anterior resection or an LAR. But as you move down to the lower third, less than 5 centimeters from the verge, sphincter preservation gets much, much harder. That often dictates a permanent colostomy via an abdomoperineal resection, or APR.
Finally, Section 6, intestinal stomas.
You really must recognize the distinct clinical profiles of these two stomas. Colostomies generally present with mechanical complications, things like peristomal hernias, prolapse, and obstipation. However, high-output ileostomies, they are entirely different beasts. They're infamous for causing profound dehydration and electrolyte derangements, mostly because they can output up to 1,500 milliliters of fluid a day before the small bowel fully adapts.
And that wraps up our intense board review explainer on the colon and rectum. We've covered the gold standard pathways, but it leaves you to wonder, right? With non-operative management for rectal cancer gaining traction and biologics completely altering IBD timelines, how will these rigid, time-tested algorithms transform by the time you're an attending surgeon? Keep that in mind as you continue to study. See you next time.